Adelaide Boylan, and I'm a GP in Norwood and also at Morph Bariatric Surgical Clinic in North Adelaide. And tonight we're going to be talking about foundations of weight management in general practice in the first of their Echo series on weight management. So we're hoping to leave this session being able to identify the key factors that contribute to overweight and obesity in the primary care setting in Australia, and to reflect on how we might take a structured patient-centred approach to initiating and taking histories about weight with our patients. It's just a little bit of background. 68% of South Australians are now overweight or obese, according to some 2023 data produced by Preventative Health SA. Obesity is the leading risk factor for preventable health conditions in South Australia. And somewhat shockingly, I think, children born in 2023, so post-COVID in South Australia, now have a 7-month reduced life expectancy compared to children born before COVID because of obesity. So this is certainly a problem we need to be working hard to address as a community, and we have a key role as health practitioners in our state. So this is a really busy slide. What I really wanted to demonstrate is that there are lots and lots and lots of things contributing to the obesity epidemic in Australia and around the world. This slide is from the Foresight report, which was published in The Lancet, but uses NHS data that's quite old now. So it was published in 2007, but I think the content of the obesity map, this is called, is still true. They also present it in this easier to read model, where we can see the biopsychosocial effects of, or the contributors to obesity. I think it's helpful to turn our minds to those factors more specifically and just think, when we're thinking about our patients and maybe ourselves, how might each of these factors be contributing to our environment? And over the process of the Echo series, we'll learn lots more about each of these, but I thought I'd just touch on different factors and provide a little bit of background. So nutrition, obviously the food we choose affects our caloric intake and our body's ability to metabolize and use and produce energy. People who are eating more healthily have brains that work better, have cells that turn over more effectively, and are generally more well. Physical activity, I think if we turn our minds to the national guidelines, we should be doing 150 minutes of pretty hard exercise per week and 2 sessions of weight-bearing exercise. I really don't think I meet all that many people in my practice or in my personal life who are getting to the level recommended by the guidelines in terms of physical activity. Genetics are a huge and obviously non-modifiable aspect of weight management. So the World Obesity Federation says that if you have one parent who is overweight or obese, you have a 65% chance of being overweight or obese yourself. And if both parents are overweight or obese, you really are likely, well, you will be obese. You have a 100% chance of being overweight or obese. So that's a bit scary. And when we think about that data around life expectancy dropping off, it's really important for us to try to start some generational change. Hormones. In our case tonight, we're going to talk a little bit about polycystic ovarian syndrome, insulin resistance. We see lots of people, I think there's lots of current media around menopause and perimenopause and hormonal changes then, as well as the sort of thyroid function type issues we might think of more commonly in the weight space. Sleep. Lack of sleep causes a physiological stress, and lack of sleep also makes people more disinhibited. So if you're tired and you're trying to stay awake to keep working, it's much easier to reach for a treat, or it's much easier to not stop yourself from reaching for a treat than if you're well rested and more able to make nutritious and healthy choices as you progress through your day. Similarly, stress stress raises your cortisol levels. I'm sure everyone has had a patient who's asked them to check their cortisol levels in a discussion about weight management, and we can talk about that more later. But whether or not your cortisol is elevated, stress certainly contributes to holding on to extra fat for many people. The obesogenic environment in which we live is a huge one. So you don't drive home from the shops and see a sign advertising have an apple, or a bus stop that has milk and eggs and cheese, or an ad for the food pyramid or the plate model of behavior choices. We see ads for fast food. We see ads for foods that are available from the inner aisles of the supermarket. And if you're feeling hungry or thirsty as you drive home, it's much easier to think, I know what I might have for dinner. This ad's influenced my dinner choice. And those environmental influences are all around us. Finally, pharmacotherapy. I just think that's something we as health practitioners need to turn our minds to. Are patients taking medications that might make them put on weight? And are we missing that? Have we educated them about that prior to prescribing? Or have we continued something that is becoming detrimental to our patients' health? Has the risk-benefit analysis changed? So hopefully that gave you a little bit of a touch on factors that influence body weight, and we'll explore that more when we get to our case discussion. The next thing I wanted to talk about was talking about weight with your patients. So I think this is really hard because for all of us, we have patients who come in with lists like this one, or this one, or actually this is more reflective of me, just feeling really stressed by the amount of things people want to get through in an appointment. And raising what can be a stressful or tricky topic cannot be something you really want to do when someone has a huge long list of issues that they're wanting to address in the appointment. I think it's much easier if a patient says to you, oh, I want to lose weight, I want to talk about my weight today. But our job sometimes is to say to someone, I think we need to talk about your weight. So I'm sure everyone recalls this case from nearly a decade ago now, but it did roll on for a while, of the gentleman who sued his GP for failing to provide him with education and advice around weight management and his cardiovascular risk. Ultimately, the finding in that case was on the side of the GP, and it was dismissed at a high court level. But I think it's a really good reminder of our responsibilities to make the hard choice and talk to people about more difficult topics, even though we might not want to, or we might feel really time stressed. Spend a bit of time thinking about how we might raise it, and having a look at the literature around this. So the College of GPs Red Book suggests that we should really be aiming to check patients' height and weight opportunistically and ideally annually, but doing that cautiously depending on the patient in front of you. So particularly someone with a history of an eating disorder, you might want to really reflect on when and maybe the appropriate moment to do that. And in pregnant patients, really could weigh someone at the first antenatal appointment, but then leave that in the hands of the person managing their pregnancy, according to the Red Book. What I do, sort of done a few different things, and I thought I'd share that. I sometimes will raise the idea of checking height and weight through the lens of accreditation and just say, look, we haven't checked your height and weight for a while. Ideally, when our practice is accredited, the recommendation is we have a height and weight for every patient annually, together with a blood pressure. So would it be okay if I checked that today? Or do you know what your weight is? I think obviously it's nicer to weigh someone in your rooms, but if they're confident on what their weight is and it gives you a figure that is hopefully semi-accurate, that would be helpful. My understanding is most people will self-report a couple of kilos below what they actually weigh, but not more than 10%. I think talking about waist circumference or waist to hip ratio as well as BMI can be helpful. All these things are just numbers, and as we all know, they're population data, not particularly relatable to the individual in front of you, but obviously used to guide recommendations, particularly around pharmacotherapy. and often around surgical management. So if someone feels that it is a difficult conversation for them, or you think actually taking into account the person in front of me, it would be valuable to check another number, that could be helpful, particularly if we reflect on the patient's genetics or perhaps their physique, if they're particularly muscular, sort of athletes and so forth who might have a higher BMI on their usual measurements, but when you did their waist circumference or their waist to hip ratio, that may well be normal. You then want to just think about, does this patient want to talk about this today? And you need to ask them, would you like to talk about your weight? Are you interested in talking about weight? Does your weight worry you? Do you think you're carrying any extra weight? Whatever may or may not suit you and the patient in front of you. I think all of these guidelines are really tricky because most of us listening this evening will know our patients really well, and you can pick the people you'll be able to ask a really direct question and the person that it might take quite a few appointments to raise the topic or to start to build a relationship and a sense of trust where you can dive more deeply into that. Similarly with smoking, alcohol consumption, nutrition, physical activity, brief interventions are highly recommended. So just saying, look, if you do ever want to talk about this, it's a conversation I'd love to have with you, but I understand if you don't want to do that for now. Again, I've used the national guidelines sometimes to say, do you realise that you're carrying more weight than would be recommended in accordance with the guidelines? The same as I would for alcohol or smoking. I think it's nice sometimes to not just talk about numbers. So non-scale victories, are there things that you would like to be able to do that your weight's prohibiting you from doing? Sometimes playing with children, tying up shoelaces, climbing up ladders, participating in activities like water skiing. Lots of different things. People will say, oh, I really wish I could still do this, but since I gained weight, I can't. And that can be as important, if not more important, than the number. So that's a lens through which you might raise the topic. And I think once you have raised it, you need to feel confident that you can provide up-to-date, realistic information, and that you can do that without the patient feeling that there's any sense of judgment about whatever these numbers or non-scale goals may be. Hopefully people are already partially, if not all the way there, with feeling that they are up to date and providing realistic information. The program will hopefully help you learn even more. So just to reinforce a couple of other models from the literature, so the SNAP guideline from RACGP and the Canadian Obesity Network both recommend that we use the 5A model. Similarly, we've seen that used again in smoking and alcohol. So exploring people's readiness to talk about something, assessing their risks and the causes, providing advice and treatment if that's what they want, making a plan around outcomes they'd like to see and some goals, and then helping make a really good plan to achieve those goals. So organising follow-up and arranging appropriate resources. The Canadian Obesity Network also talks about this 4M model, which I hadn't heard about before, but is actually quite an interesting lens maybe to reflect more on a patient after you've seen them than as a model to apply to a patient in mid-consult. But it is useful to think about the first M, metabolic, how the body's metabolic processes might be affecting obesity, thinking about inflammation, insulin resistance, hormones, and using that data or any questions you've asked around that to influence tests you might order. Mechanical, thinking about your joints, mobility issues, reduced physical function, how that might be affecting those non-scale victories or goals. The link between mental health and obesity is obviously really strong, and addressing mental health concerns is crucial to successful weight management. And finally, monetary. The cost, both at an individual level and at a societal level of A, obesity, but also B, weight management, can be significant through many different lenses. And so trying to think about how we can support our patients to lose weight, to therefore support the healthcare system to be looking after more well people. So coming back to taking a history, I try to use that same thought process as we saw in the map at the start of this presentation. So I try to ask a patient, what's their weight journey been? Most people will have lost and gained weight, often losing weight and then gaining back that weight plus a little bit more as their metabolic situation gets, I guess, arguably increasingly confused by their nutritional choices and or either modifiable or non-modifiable risk factors for obesity start to impact on their weight. I think it's nice to ask people about non-modifiable risk factors initially. I think everyone's looking for a cause for their obesity that they don't feel any blame for or that's not their fault. Not that any of this is their fault. This is a societal problem. But I tend to start with genetics and talk about hormones because it perhaps medicalizes the conversation a little bit, or it flags that we're just going to step through all potential risk factors for obesity. And then move more into the potentially modifiable risk factors. They're not necessarily modifiable. People can be really limited in their physical activity. Hormones I put in both piles because I thought some hormonal problems you can modify, others are much more difficult. And then sleep, stress, and pharmacotherapy as things we definitely don't want to forget. So think about that 5A model. After you've taken the history, you need to help your patient to think about what could be contributing to my obesity and what's a plan that we could agree on that we can start to work towards. This is not a one appointment kind of like went to the doctor and I lost all my weight and I'm doing fabulously now. I think we all know that. And if that was the case, we wouldn't be needing to have this meeting and we'd be out of a job. So you want to really support your patient by making a high quality plan with opportunities to check in and catch up, providing that up-to-date realistic information and really engaging with a team-based approach. The best outcomes in terms of sustainable weight loss are where people are doing lots of things. So not just changing their diet, not just adding exercise, not just changing their medications, really starting with those foundational things, trying to eat to the guidelines, trying to exercise to the guidelines, and then doing the additional things on top. So thinking about that pyramid style model where the base is right and making sure you're available for follow-up. Just in terms of the idea of realistic up-to-date information, I just thought I'd pop this slide in because I think it will frame some of our discussion later on. So if people weren't aware of kind of what we would expect to achieve with different primary treatment options for obesity, I think this is very useful data to just have in the back of your mind as we start to talk through the early cases in the ECHO program. And finally, I think it's important to flag with our patients and reinforce that we know that this is really hard. The vast majority of people will think that weight loss is going to be easier, faster, that they'll lose more weight, and that it will change their life more than it actually does. So weight loss is hard work. It can be a bit of a slog. You're not going to wake up markedly lighter in terms of scale numbers tomorrow, and we need to be realistic about that from the start. Otherwise, it can be really difficult to support your patients to achieve their goals. Finally, some useful resources. The first two are Australian resources, NACOS and the National Framework for Obesity. The NACOS website particularly has some great resources. The World Obesity Federation runs a program called SCOPE, which has webinars and also an annual education day, which is extremely helpful to catch up and feel up to date on weight management. The Canadians are further ahead than our guidelines on GP-based management of obesity, so worth having a look at their website, and then the Red Book and the SNAP program on RACGP. And finally, I wanted to acknowledge all my lovely colleagues at Morph from whom I've learned so much as being part of the multidisciplinary team there. So that is the end of my presentation. Thank you very much, everyone.